We are live now. Good evening, everyone. And Dr. Vikas, please continue.
Yeah, sure. Thank you so
Dr.
much.
V, sir, do we begin, sir?
Yeah. I think we should. Sir, Dr. Naveen, is he
Sir, has, sir.
joining?
Yeah, he has already joined, sir. Sir, ki hai. Naveen, sir, with your permission, sir, should we start, sir?
Let's start.
Good evening, sir. Right,
Yeah.
sir. Dr. Vikas, please carry on, sir.
Sir, good evening.
So, on behalf of RSACP Indore branch, Dr. Vikas Gupta would like to welcome all the delegates and speakers, chairpersons, and our national president and national secretary to this another academic session of RSACP webinar. And it is today's webinar theme is prevention, protection, and progress in neuro-anaesthesia. So we are now taking neuro-anaesthesia on this webinar, and I would like to invite Naveen sir for his welcome address now.
Thank you, Dr. Vikas, and welcome all to the second session on neuro-anesthesia as a part of RSACP academic webinar series. A fortnight ago, we had the session 1 on neuro-anesthesia by RSACP Guwahati Little branch, and now we have got the second session on precision, protection, and progress in neuro-anesthesia by RSACP Indore City branch. I'm very glad that the organizing committee of RSAP Con 2026 is actively involved in conducting this webinar under the able leadership of Dr. K.K. Arora sir, Madam Meenu Chadda, Dr. Gaurita, dear Dr. Chauhan, Dr. Mayank, and very dear Dr. Vikas Gupta. And the topics chosen are very nice: traumatic brain injury, neuromonitoring, and EVAs. I'm very sure that it will be a very good learning experience for the faculty and the delegates alike. Best wishes to all of you. Thank you very much.
Now I would like to invite Dr. Vishal Singla, our National Secretary RSACP, for his welcome address.
Good evening, and thank you to each and every one of you for being here with us today. As we know that RCCP is always promoting academics and is pioneer in promoting academics, and we have been holding webinars since long, ever since the COVID periods, to keep abreast with the latest and everyday topics. Continuing in the same series, same spirit, we are continuing with the neuro-anesthesia series, part 2, with the relevant topics. For today's topics, I would like to thank our RSACP team in Indore, Dr. Madam Meenu Chadha, Dr. K.K. sir, and the team. When they have the webinar is very much well crafted and the very relevant and important topics. I would also like to thank our chairpersons, our speakers, with whom I'm sure the discussion is going to be very interesting and lively. Once again, I would like to thank every one of you for being with here today. Thank you very much and best wishes. Over to you, Dr. Vikas, please.
Yeah, thank you, Dr. Vishal. And as Naveen sir said, we are organizing a 2026 RSACP National Conference at Indore. So we'll be happy to welcome you all there. And now I'd like to introduce our chairperson first. I would like to invite Dr. Kishore Arora sir. He's Director of Saints Medical College Anesthesia Department. Then Dr. Meenu Chadda madam. She is a Senior Consultant and Head of Department of Anesthesia and CHL Care Hospital. And Dr. Mayank Hasan, he's a Senior Consultant looking after Onco and Neuro at Jupiter Hospital, Vishesh Hospital at Indore. So now with this, I think we should start our webinar, and I would like to invite our first speaker, Dr. Gaurita. She's a Senior Consultant from Bombay Hospital in Indore, and she will be speaking on optimizing anesthesia for traumatic brain injury. So over to Dr. Gaurita, please. Are you able to share your screen now?
Now, ma'am, you will be able to share your screen. Dr. Gaurita, please go ahead. Make it to the full screen, ma'am, please.
Yeah. Am I audible?
You're audible, ma'am. Please make it to the full screen.
Yeah. Yes, sir. Good evening, everyone. National Secretary, National President, RSACP, and respected Arora sir, Meenu ma'am, and all my friends and colleagues. I'm Dr. Gaurita Srivastav, consultant at Bombay Hospital, and I will be speaking on the recent guidelines from an anesthetic perspective for the management of traumatic brain injury. So traumatic brain injury is an insult to the brain from an external mechanical force which leads to temporary or permanent impairment of physical, cognitive, and psychosocial functions. The incidence is nearly 1.5 to 2 million people who are injured, and nearly 1 million people succumb to death, and 500,000 require rehabilitation services every year.
I'm
So
sorry
this-
to interrupt you, ma'am. Please make it to the full screen, ma'am. Button
sir,
on the right side, ma'am. Please come on the right side, lower right side, ma'am. There are 3 buttons, just adjacent to 90%. Just adjacent to 90%. No.
Yeah.
Left, go left. Yeah, left, please. Left.
This
Go
one.
left.
Yeah.
Left. Yes,
Sir,
this one. This one.
Is this okay?
Yeah, just click it.
Just click it, ma'am. Just adjacent to 90%. Click it, ma'am.
Just adjust to 90%, click it. That timeline.
The one button which you have, yes, on the adjacent to the 90%, ma'am. Please click it.
Is it okay?
No, ma'am, you have made it to 120%. Make it to 90%. Yes, please click this. Yes. No. Left to the 120%. Left to the 120%, ma'am. Just button
This
which is
one?
there. Yes. Press it, please.
Just a minute. Sir, I had clicked on that one only.
Okay, you can go from the top slideshow from the beginning.
Yeah, I had done that only, ma'am.
No, it's not full screen yet.
Okay. Is it full screen now?
No. You go on slideshow.
Yes,
Yeah.
now
Yeah.
please go ahead.
Okay. Am I audible, ma'am?
Yes, ma'am. Please go ahead, ma'am.
Okay. So as we can see, the causes of traumatic brain injury, maximum reasons of traumatic brain injury are because of falls, traffic accidents, or being struck by or against, and then assaults. So various types of brain injuries include concussions, contusions, brain hemorrhages, intracranial hematomas, contacoup brain injury, diffuse axonal injury, and penetrating brain injury. So as anesthetists, where do we come into the management of traumatic brain injury? It starts right from the level of the triage to pre-hospital care, intra-hospital care, and then post-op rehabilitation as clinical intensivists. What do we mean by triage? Triage is actually the rapid, accurate evaluation of patients on site of the injury to determine the extent and to take the appropriate medical care required. So we have to decide which patients are to be transported. The seriously injured patients should be transferred to the best equipped medical trauma centers, and at the same time, unnecessary transport of other patients should be avoided so that the medical care facilities are appropriately given. At the time of transport, the most important thing is that full spinal immobilization of these patients is prudent. So the patients who have to be transported to the higher trauma centers include patients with a Glasgow coma scale less than 13, patients who have obvious signs of basilar skull fractures, and also patients with penetrating head injury. So we now start with the basic assessment of patients on site. The most important thing, as we all know, for assessment of the patients is the Glasgow coma scale, which I will be describing in detail. Also the pupillary right response, and a more accurate and objective method of assessing the pupillary response is the quantitative pupillometry, which eliminates the errors which occur because of use of various vasodilator, pupil dilating drugs, and if patients already have pre-existing diseases. So this quantitative pupillometry will be more accurate for measurement of the reaction to light. So what are the goals of management? I have included this slide in the beginning because these goals for management remain the same irrespective of whether the patient is on site of the trauma, in the pre-hospital care or pre-anesthetic care, intraoperative and post-operative. So the main goals for management of traumatic brain injury include airway management, oxygenation of the patient, providing hemodynamic support, and intensive care treatment to avoid secondary injuries. So pre-hospital management or on-site management includes management of airway, wherein we identify and treat the hypoxia, which is defined as a saturation less than 90% and or patient having cyanosis. In these patients, continuous high flow of oxygen should be administered at the time of transport. Airway repositioning maneuvers can be attempted, which include bag mask ventilation and use of airway adjuncts such as the oral airway, nasopharyngeal airway in case there is no suspicion of the skull base fracture, and use of a laryngeal mask airway. At the time of intubation, we must keep in mind that the patient could be having pre-existing hypoxia, intracranial hypertension. He may also be full stomach and have coexisting cervical spine or maxillofacial injuries. So all these patients are potential difficult intubation, and intubation has to be attempted with a manual inline stabilization. As far as ventilation is concerned, even at the time of transport, try to keep the ventilatory rate in children around 20 breaths per minute and in adults 10 breaths per minute in order to achieve an EtCO2 between 35 to 45 millimeters of mercury. There is no evidence of any role of prophylactic hyperventilation even in patients with traumatic brain injury in the early stages. Mild therapeutic hyperventilation can be given only when there are obvious signs of herniation. As far as blood pressure management is concerned, a systolic BP less than 90 millimeters is considered to be hypotension, and it has to be aggressively treated on all fronts. IV fluid resuscitation with a balanced salt solution or crystalloid, which is non-glucose containing, such as RL or NS, can be used. Treatment of hypertension in acute traumatic brain injury is not recommended, and the IV fluid has to be restricted to a minimum peep open rate in the patients with systolic BP, which is greater than 140 millimeters of mercury. I'd like to just mention that all these recommendations are from the Brain Trauma Foundation, which has given its latest guidelines and recommendations in 2024. This is the most widely followed guidelines as far as traumatic brain injury is concerned. So now we come to the Glasgow Coma Scale, which includes, as we all know, eye opening response, verbal response, and motor response. Amongst all these, the motor response is the clinically most relevant. Sometimes they also categorize it as a GCMS. That is the Glasgow Coma Motor Response Scale. Maximum importance is given to the motor response of the patients, but depending on the entire scale, it is classified as minor with 13 to 15, moderate as 9 to 12, and severe brain injury as 3 to 8 points. In addition to the Glasgow Coma Scale, a new scale has been introduced by the Brain Trauma Foundation, which is known as the 4 score, or a full outline of unresponsiveness score, which attends to certain fallacies or shortcomings of the Glasgow Coma Scale. It additionally has the brainstem reflexes and the breathing pattern also included. Each of these parameters has a scoring from 0 to 4. So the total range is from 16, wherein the low scores suggest a decreasing level of consciousness. So this score is more relevant, especially when patients are intubated or in comatose patients, because they are assessing the brainstem reflexes as well as the breathing pattern. So after we do an initial assessment of the severity and calculate the Glasgow Coma Scale, this is the flowchart for maintaining the patients. In mild traumatic brain injury, you just have to monitor the patients, and there is no worsening. They can be discharged 6 hours after observation. All patients with moderate or severe traumatic brain injury need to go for an urgent CT scan and a neurosurgery consultation. So the main aim of the triage and immediate shifting of patients to higher centers is for the prevention of the secondary injuries. So traumatic brain injury is basically of two types. The primary insult, which occurs at the site of the trauma, and which is followed by secondary injuries which occur because of the following reasons: that patient has hypoxia, hypotension, hypercarbia, hyperglycemia, hyperthermia, or seizures. So it is any of these events which lead to further secondary damage to the patient, which is the main aim or goal of the clinician or the intensivist, to prevent any further secondary brain injury to the patient. So once we reach the hospital, this is an in-hospital assessment. The patient is to be stabilized. All other forms of trauma, injury to the chest, abdomen, all other trauma is to be ruled out, and the same goals of management are to be pursued. The risk stratification is done and confirm the diagnosis. If required, the patient has to be sedated, and adequate amount of analgesia is to be given, because any raise in BP could also raise the intracranial pressure, which could be detrimental. So we have to give adequate sedation, analgesia, at the same time maintain the mean arterial blood pressure. The drugs which we use are, as mentioned, midazolam, dexmedetomidine, propofol, opioids, and nowadays ketamine has also come back into vogue. So the most popular imaging modality is the CT scan, which is the primary modality of choice because it is safe, quick, and it is readily available. MRI can also be done, which is more accurate as far as intracranial pathologies are concerned, but it has its disadvantages, that it requires more time and sometimes may require sedation. In addition to this, there are also the latest recommendations. I have found that there are certain biochemical markers which I have mentioned here, GFAP, UCHL1, and S100, which can be measured in case, like at that time, they could rule out the cause for CT scan. Because if they are grossly elevated, then you can tell the amount of neurological damage. So pre-op assessment includes initial evaluation, clinical assessment, history taking, physical and neurological examination of the patient. Then we move on to optimization, wherein if these conditions are not corrected, then we optimize the airway, assure hemodynamic stability, correct all electrolyte imbalances, arrange blood products, continue all the ongoing medications, and take a written informed high-risk consent of the patient. So this is, in nutshell, actually my entire presentation. The goals of our presentation of goal-directed therapy are on this slide, which is what we should try to maintain throughout when we are dealing with traumatic brain injury patients. Keeping a pulse oximetry of greater than 94%, a PO2 of 80 to 100 millimeters, PCO2 between 35 to 45 millimeters, a systolic blood. Sorry? Ma'am, you saying something?
You can continue it.
Systolic blood pressure greater than 100 millimeters. Intracranial pressure should be less than 22 millimeters. Oxygen saturation should be greater than 15 millimeters of mercury. A cerebral perfusion pressure between 60 to 70 millimeters of mercury. Serum sodium 135 to 145. Osmolality less than 320 milliosmoles. INR less than 1.4. Temperature between 36 to 37.9 degrees. Platelet greater than 75,000. pH 7.35 to 7.45. Glucose between 100 and 180 millimeters of mercury, and a hemoglobin of greater than 7. So all the methods should be done in order to keep the parameters within these goals. So we have to avoid any sedation depending on the level of the consciousness, but antacid prophylaxis and anti-secretory agents are to be given. The choice of anesthetics depends on the need for rapid airway control. They should cause minimal increase in the intracranial pressure and also give hemodynamic stability. So propofol can be used, succinylcholine or rocuronium both. Non-depolarizing muscle relaxants are to be administered for maintenance. Volatile anesthetic agents, if used at a MAC of less than 1, do not cause much of increase in the intracranial pressure, so they can be safely used. And opioids, NSAIDs, and for reversal, the latest magical drug, Sugammadex. So intraoperative targets include maintaining hemodynamic stability, as I have already mentioned, management of coagulopathy, which is very important, and temperature control and prevention of hypothermia. Oxygenation, as I had mentioned, you have to adjust to achieve a PO2 of 90 millimeters. Avoid any higher PO2 because there is chance of cerebral vasoconstriction as well as lung injury. Administer PEEP, and the decision for tracheostomy depends on the need for long-term ventilation. So you have to weigh the risk-benefit ratio. For ventilation, we avoid hypo as well as hyperventilation because in hyperventilation, there could be tissue hypoxia, and the volume controlled mode is the preferred mode. The Trauma Brain Foundation guidelines are to keep a systolic BP greater than 100 millimeters for up to 70 years and 110 for more than 70 years. Judicious use of ephipres, phenylephrine, or in more extreme conditions, noradrenaline, vasopressin are used to maintain the BP. So in the fluid management, all non-dextrose containing solutions are recommended. So NS, RL, or now the balanced crystalloid salt solutions. We have to avoid all hypotonic solutions, and colloids are not known to give any proven benefit. It is the volume of the fluid rather than the choice of fluid which makes all the difference. So the ideal maintenance of the cerebral perfusion pressure, which is the difference between the mean arterial pressure and the intracranial pressure, is to be kept between 60 to 70 millimeters of mercury. So we have to try to avoid all the medicines or all maneuvers which may increase the intracranial pressure and also maintain the BP. Intracranial pressure monitoring is to be done to maintain the intracranial pressure to less than 22 millimeters. And the EVD is the gold standard, or the external ventricular drain, which is connected to a pressure transducer, which can be both diagnostic as well as therapeutic, is the gold standard for monitoring the intracranial pressure. And it should be used in all salvageable patients with a Glasgow coma scale of 3 to 8 after resuscitation and an abnormal CT scan. So after the external ventricular drain, it is used to drain the CSF, but at the same time, the disadvantages are that it is an invasive procedure, it is technically challenging and holds the risk of infection. Neuromonitoring is going to be covered by my colleague, so I will skip this slide. The surgical considerations for release of the intracranial pressure include the decompressive craniectomy, which is a bone flap removal in order to reduce the intracranial tension. And this has proven with a frontotemporoparietal incision, it has proven to reduce the mortality, but at the same time, it increases the morbidity. Anticonvulsant therapy is to be started on all patients within 7 days of injury, and either Eptoin or levetiracetam can be used. No drug is superior over the other. Maintenance of normothermia is of major relevance because and at the same time, prophylactic hypothermia is not improve outcomes. Blood sugar has to be maintained between 80 to 180 milligram per. There can be associated hyperglycemia in these patients because of the increased sympathetic activity. So glucose containing solutions must definitely be avoided. Nutrition is of paramount importance. Early nutritional support should be given to the patients. Enteral nutrition is supposed to be more. And the Brain Trauma Society recommends a basic caloric replacement by at least the 5th day and maximum the 7th day post-surgery. A feeding jejunostomy can be associated. A replacement of 140% should be done in non-paralyzed patients. And in paralyzed, is also very important because these patients are bedridden. A lot of them are intubated on ventilator. So we have to avoid the DVT and its subsequent consequences. So compression stockings or intermittent pneumatic compression can be used. Pharmacologically, we can do it with the help of molecular weight heparin or the newer antibiotics. This normally started 48 to 72 hours after neurosurgical intervention and in the absence of any contraindications. And the pediatric age group is a special population because it has they have larger head and the stability is more dependent on the ligamentous structures rather than bony structures. And these patients may tolerate raised intracranial pressure better than the adults. So we use a modified pediatric GC scale in these patients, wherein the verbal response is mostly different from what it is in adults. Post-operative care, we have to continue the ICU management and neurocritical care, avoid secondary brain injuries, use various rehabilitative modalities wherein use of physiotherapist, occupational therapist, speech therapist is of utmost importance because these are long-term patients with long-term disabilities. So they have to be catered to properly. Early detection and management of complications has to be done judiciously. So there is a multidisciplinary approach and psychological support is also very essential for these patients. So to conclude, guidelines are established to use evidence-based therapeutic approaches to decrease variations in patient management and improve functional outcomes. The Brain Traumatic Society are the most widely used guidelines, and better clinical outcomes we will always get if there is a combination of improved pre-hospital and critical care experts. Prompt interventions are recommended to limit the secondary brain injury and to improve long-term outcomes. So this is the take-home message. Maintain oxygenation, ventilation, and hemodynamic stability. Follow evidence-based approaches and protocol-driven management strategies. Focus on improved pre-hospital and neurocritical care, and limit the secondary brain injuries for superior patient outcome. Thank you. Any questions?
Thank you, Dr. Bharata, for your insightful presentation, and we'll take the questions in later discussion part.
Just an introduction of the RSACP Con. As we are all aware, Indore is going to be hosting the RSACP Con 2026 conference. So an invitation to everybody for kindly block your dates for the 10th to 12th of April 2026 and register as soon as possible. Thank you.
Thank you, Dr. Bharata. Now I'd like to invite our next speaker, Dr. Radhika. She is a senior consultant at Bombay Hospital, Indore, and she'll be speaking on neuromonitoring in modern anesthesia, its innovations and application. So, Dr. Radhika.
Thank you, sir. I am unable to share my screen as well. So can I please request Dr. Deepti ma'am to start her presentation? I'm unable to share my screen. There's some system problem in my laptop. I'll just sort it out.
Okay, then we continue with Dr. Deepti presentation, and she will
No, I think Dr. Vishal
Or
will have
should I
to
let
allow
me
him
talk
to
Vishal?
share
Yeah,
his
let's
her
talk to
slides, no?
Vishal. I hope.
Ma'am, now you can, now ma'am, you
Yeah.
can present, please. You have been made the co-host. Please go ahead, ma'am.
Sir.
Now please share your screen.
So actually, this problem is not with you allowing me to share. The problem is that there's something in my system settings which is not allowing me to share. I have to change the system settings. So,
you are with iPad, kya?
no, I have a laptop, but there's some system settings that I have to change to allow.
What you can do is you forward it to Gorita and let
Okay, sorry.
Gorita change the screen for you and you speak. You mail it to
Sure.
Gorita.
Okay, sir, I'll do that. But that will be like, that'll take some time, sir. Can we...
Hope anybody else.
I think we can continue with Dr. Deepti's session.
Yeah, please.
Dr. Deepti, are you ready with presentation?
Yes. Just a second. Should I start sharing my screen?
Yeah, please go ahead, ma'am.
Let me introduce you. Dr. Deepti is head of department at Government Super Specialty Hospital in Indore, and she will be speaking on ERAS after neurosurgery. Dr. Deepti, you can continue.
Just a second.
Yeah, sure.
Are you able to see my screen?
Yes, ma'am, it's with. But yeah, please on your PPT, ma'am.
Yes, just a second. Is it visible?
Yes, please.
Okay. Respected office bearers, chairpersons, and seniors, dear colleagues and students, a very good evening. At the very outset, I would like to thank the office bearers of RSACP for giving me this opportunity to speak on an important topic, that is ERAS protocol in neurosurgery. Now, for the next few minutes, we will be navigating around the brief introduction of ERAS protocol, whether it is needed in neurosurgery, especially craniotomy, components of ERAS relevant in neurosurgery, challenges faced in the implementation of these protocols in neurosurgery. Now, the concept of ERAS was introduced in 1997 by Gallagher and Wilmore in colorectal surgeries. It is based on evidence-based practices covering interventions before, during, and after surgery, that is in perioperative period. It is associated with shorter duration of hospital stay, reduced opioid use, lower readmission rates, reduced incidence of ILS, PONV, and delirium, and fewer surgical complications. It involves multidisciplinary team, including surgeon, anesthesiologist, nurse, physiotherapist, and nutritionist. Since its inception, this concept has grown by leaps and bounds, and ERAS Society was established in 2010 in Sweden. It has endorsed clinical guidelines for more than 20 surgical subspecialties, including lumbar spine surgeries in 2021. However, there are no guidelines as such for cervical spine surgery, anterior approaches, and complex deformity procedures, particularly idiopathic scoliosis, and definitely no guidelines for cranial surgery as such. So, whether do we need these ERAS protocol in neurosurgery? Craniotomy is a common neurosurgical procedure, creating burden on healthcare systems. 30-day complication rates are significantly more in patients having cranial surgery compared to spine surgeries with prolonged ICU care needed. Maximum complications are seen in skull-based surgeries and require prolonged length of stay, which leads to poor outcomes. So integration of ERAS protocol in these cases will enhance surgical outcomes through reduction in stress response and decrease postoperative complications and improve patient satisfaction. The components of ERAS protocol, especially in neurosurgery, include four-pronged approach, starting right from pre-admission, optimization, pre-operative optimization, intraoperative interventions, and post-operative interventions. Now, since there are no guidelines for cranial surgery, we have formulated, the ERAS Society have formulated guidelines for lumbar spinal fusion surgeries, but there are no guidelines for other spine surgeries as well as no guidelines for cranial surgeries. So what I have done is I have done a literature search, and what I found was that most of the literature available for cranial surgeries has been accumulated in the short time span of starting from 2020 till date, and most of the studies have based their work on the cult study of Hagan et al. Conducted way back in 2016. It included 17 components of ERAS protocols. So most of the components have been are similar in spine surgeries as well as cranial surgeries as formulated by Hagan et al. And that is what I have done. I have compared the two guidelines in the same manner. So the work of ERAS start right from pre-admission, including education and counseling, which has a very strong recommendation both in lumbar spine fusion surgeries as well as cranial surgeries. The education and counseling should involve a full detailed description of the procedure as well as expected outcome. And if it is in the form of a flyer diagram, it is all the more good. In cranial surgeries, careful patient selection forms the backbone of ERAS protocol. Rehabilitation, which includes improving the functional status of a patient by exercise, nutrition, and psychotherapy. It has got insufficient evidence in lumbar spine surgeries as well as in cranial surgeries. However, nutrition is very important in both the conditions, in both the surgeries. And I will be talking about it in the next slide. Cessation of smoking should be done for a minimum of 4 weeks and alcohol cessation for 4 to 8 weeks in lumbar spine surgeries, while a month of abstinence from alcohol and smoking whenever feasible in cranial surgery should be done. Now, nutritional assessment and management is very important in nutritional risk screening should be done using tools like subjective global assessment, controlling nutritional status, and prognostic nutritional index. And it is 3-pronged. Actually, this nutritional assessment and management starts right from pre-admission, continues in pre-operative period and post-operative period as well. In the pre-admission period and pre-operative period, if there is increased biochemical markers like pre-operative albumin levels, if they are less than 40 grams per liter, lymphocytes and cholesterol levels, they are associated with bad prognosis. Now, for rehabilitation, enteral route is preferred whenever it is indicated. Parenteral route should be chosen only for very sick and malnourished patients. Now, there is a concept of immunonutrition, which should be given 5 to 7 days before surgery. It is known to boost immunity. And in this, we give a formulation of various nutrients which boost immunity like arginine, glutamine, probiotics, and glutathione, etc. Another important aspect of nutrition is correction of iron deficiency anemia by oral and IV iron supplement. Now, there are no cutoff values or target values of hemoglobin as such. There is no consensus regarding the hemoglobin values. And we have a wide range of articles which support a range of 7 to 10 gram per deciliter of hemoglobin. Hemoglobin higher than 10 might be associated with thromboembolic phenomena, and lesser than 7 may lead to cerebral ischemia. So Correction of iron deficiency anemia is very important by oral or IV iron supplement. Once the nutritional deficiencies have been excluded, erythropoiesis stimulating agents such as erythropoietin are recommended for anemic patients. Important aspect of nutritional assessment and management in preoperative period includes oral nutrition supplements with 12.5% maltodextrin 2 hours before surgery, which improves post-operative glycemic control, and early resumption of oral feeding in post-operative period further exacerbates the recovery of the patient. So now preoperative optimization includes preoperative fasting levels, which include recent guidelines of clear fluids up to 2 hours and solid food up to 6 hours in both lumbar spine surgeries as well as in cranial surgeries. Carbohydrate loading has got an insufficient evidence in lumbar spine surgeries, but surprisingly, in cranial surgeries, carbohydrate loading has been found to have a good effect, and it should be done so as to improve glucose homeostasis in post-operative period due to decreased insulin resistance. Sedative and anxiolytic drugs should be avoided in both lumbar spine and cranial surgeries as such. However, seizure prophylaxis is recommended in cranial surgeries, with levetiracetam being preferred over phenytoin. Now, preemptive analgesia is important component of preoperative optimization. In lumbar spine surgeries, it can be done using acetaminophen, NSAIDs, and gabapentinoids as a part of multimodal opioid sharing analgesic strategy, which is recommended. But in cranial surgery, there is insufficient evidence on the efficacy of gabapentin, pregabalin, tramadol, and NSAIDs. Preemptive analgesia with acetaminophen, scalp block, and local anesthetic infiltration is propagated. Intraoperative interventions include 3 important prophylaxis: antimicrobial, antithrombotic, and antiemetic. Antimicrobial prophylaxis in lumbar spine surgeries should start 30 minutes before skin incision and should be repeated every 4 hours. Skin preparation using alcohol-based iodine or chlorhexidine solution should be done to reduce surgical site infections. In cranial surgery, antimicrobial prophylaxis should be done within 1 hour prior to skin incision, and prophylactic MRSA treatment with vancomycin is preferred. Scalp shaving should be minimized so as to reduce surgical site infection. Now, the lumbar spine surgeries is basically has a low incidence of thromboembolic phenomena. So, chemoprophylaxis is not indicated. Early ambulation and mechanoprophylaxis suffice. While in cranial surgeries, there is higher incidence of thromboembolic phenomena. So, there should be a combination of mechanoprophylaxis as well as chemoprophylaxis. However, mechanoprophylaxis is preferred over pharmacoprophylaxis, and it can be done using graduated compression stockings and intermittent pneumatic compression devices. Antiemetic prophylaxis should be given after performing a preoperative risk scoring like EPFL. Use of multimodal PONV prophylaxis should be done. It includes dexamethasone and 5-HT antagonist, which is recommended at the time of induction of anesthesia, especially in cranial surgeries. PONV rescue, that is, once there is a setting of PONV, rescue antiemetics should belong to a different class, including second-line drugs such as antihistamines, for example, promethazine, anticholinergics, for example, scopolamine, and other dopamine antagonists such as metoclopramide. In case of spine surgeries, the use of multimodal PONV prophylaxis should be based on assessment. However, cranial surgeries have a higher incidence of PONV in comparison to spine surgeries, as high as 47%. There is increased risk of elevated intracranial pressure, brain edema, intracranial bleeding, and aspiration of gastric contents. So, in these, multimodal prophylaxis is recommended at the time of induction of anesthesia. Now, the anesthesia technique preferred in lumbar spine surgeries are neuraxial techniques, including spinal and epidural. However, no difference has been found when compared with general anesthesia. If general anesthesia is used, use of muscle relaxant is favored, as it decreases airway pressure and muscle damage associated with prolonged retraction. Use of dexmedetomidine and ketamine for better pain control is recommended. In cranial surgeries, there is no strong evidence to support the superiority of short versus long-acting anesthetic drugs or TIVA versus inhalational anesthesia. Use of medications with minimum effect on cognition and orientation, like dexmedetomidine and magnesium sulfate is preferred. Ketamine, long-acting opioids, and nitrous oxide should be avoided. Although this ketamine is a bit, it has got weak evidence, and mostly it is advised against, and it should not be used. The surgical technique that is preferred is mostly minimal invasive, both in case of lumbar spine surgeries as well as cranial surgeries. However, in spine surgery, it should be decided on a case-to-case basis, factoring surgery goals, training, and experience of the surgeon, and it should not be dictated by ERA's protocol. However, in cranial surgery, awake craniotomy, minimally invasive craniotomy with use of intraoperative neuronavigational system, endoscopic skull-base approach, all of these are preferred wherever feasible, with careful dural handling, with small linear scalp incisions. Absorbable sutures, they increase patient satisfaction. They are known to increase patient satisfaction. Perioperative fluid management aims at in lumbar spine as well as cranial. Now, goal-directed therapy is not needed for one to two levels of lumbar fusion. It should be considered only if significant comorbidities coexist. But in cranial surgery, goal-directed fluid therapy is recommended. Non-invasive cardiac output monitoring being more accurate to determine volume status in these patients. Temperature regulation is an important aspect of ERA's protocol and should aim to maintain normothermia. Hypothermia increases coagulopathies and decreases drug metabolism, while hypothermia increases metabolism and exacerbate neuronal injuries. Even 10 minutes of pre-warming reduces adverse outcomes by preventing hypothermia. Circulating warming garments offer better temperature control than forced air warming systems. Post-operative interventions include early return to normal diet, which is recommended, as I have already mentioned, in both spinal as well as cranial surgeries. Urinary catheterization is another important aspect which should be avoided as far as possible in short segment elective lumbar spinal fusions and removed as early as possible where feasible. Similarly, in cranial surgery also, the urinary catheter should be removed on post-operative day 1, if feasible, and if not, regular assessment of the need for maintaining the catheter should be done. Post-operative artificial nutrition is not needed except in prolonged comatose state in cranial surgeries. Early mobilization is recommended both in spine surgeries as well as cranial surgeries, and audit whichever way it is feasible should be done. Now, I have taken this chart from a very recent study published in April 2025, and it tells about the ERAs in adult corrective spine surgery. Yes, basically, it involves all the components that I have mentioned before, but it includes one important concept in preoperative, which is psychological assessment and behavioral health, which was missing in lumbar spine fusion surgeries, and another one in intraoperative, which is minimizing estimated blood loss and OR time, and liberal use of tranexamic acid in both as bolus as well as infusion. Now, this is another chart which I borrowed from Ranjit K, from an article published by Ranjit HK, and it determines the procedure-specific ERAS component. Like in cervical spine, it is early collar removal, which decreases length of stay. Deep brain stimulation, it is local anesthesia with minimal sedation and same-day discharge, which again decreases length of stay. And in CSF shunt procedures, it is early ambulation and minimized narcotic use, which decreases length of stay and readmission rates. Now, what are the challenges that we face in implementation of ERAS protocol in neurosurgery? First and foremost is the lack of coordination amongst team members providing care for patients from the pre-operative through post-operative phases. What happens once the anesthetist has done his pre-anesthetic checkup? He finds some nutritional deficiencies. It is very important that these findings should be conveyed to the team, to the surgeon. Implementing ERAS for urgent and emergent cases is challenging due to patient equity and complexity. The current research remains fragmented, with many studies focusing on perioperative procedural design rather than holistic interdisciplinary implementation of care for the patients. So all these challenges lead to reduced implementation of ERAS protocol in neurosurgery. This can be improved if we follow the channel of communication, action, and implementation without interruption. So to summarize, ERAS is a safe and favorable multimodal perioperative pathway in patients undergoing neurosurgery. Its components are interconnected with use of one component facilitating another component. These protocols have found to reduce length of stay and cost of hospitalization without increasing post-operative complications or compromising patient satisfaction. Continued research is required in cranial surgeries and certain subset of patients in spine surgeries. Thank you very much. But before I end, I would again like to extend, I would like to invite all of you for the 34th Annual National and 5th International Conference of Research Society of Anesthesiology and Clinical Pharmacology, which is to be held at Indore from 10th to 12th April 2026. Please, you all are very welcome, and please register. Thank you very much.
Thank you, Dr. Dipti, for your nice presentation, and I'm sure your presentation will motivate people to apply last protocol of neurosurgery.
So,
yeah.
It's an entirely.
And it's my humble request to all participants, please keep your device mute while presentation. So, Dr. Radhika, are you ready now?
Sir, I am. Gorita ma'am will share my screen for me. I was trying to reach the house, but I'm on the way, so I'll just make do. Gorita ma'am, can I ask you to share your screen for me, please? I'll just give her a call.
Yeah, Dr. Radhika, you can unmute yourself.
Yeah. Okay. Good evening. So my topic is neuromonitoring in modern anesthesia and its applications. So first, why do we need it? Do we even need to monitor the brain? It's only just the most important organ in the body. Of course, there are anesthesia-related indications such as depth of anesthesia monitoring and awareness monitoring, and on the other extreme, coma. And other things that need are post-operative delirium and cognitive dysfunction, which are anesthesia-related. And then the obvious reasons to monitor the brain is to prevent neural injury or diagnose the neural injury and then prognosticate it if it does occur. Next, can I have the next slide, ma'am, please? Okay, so as such, there is not a classification of neuromonitoring techniques. Just to streamline this talk, I have divided it based on electrical activity of the brain, which can be spontaneous electrical activity, and evoked potentials monitoring, which is evoked electrical activity, basically. Then the second thing is it's based on cerebral perfusion in the next slide. And there are several monitors which are based on cerebral perfusion, such as ICP monitoring and transcranial Doppler ultrasound, near infrared spectroscopy, etc. And the third is the use of biomarkers. there are various proteins that have been used to indicate the severity of injury, neurofilament light chain protein and glial fibrillary acidic protein, etc. So starting with the monitoring based on brain electrical activity. What we have here are spontaneous electrical activity, which is the EEG. So as everybody says now that processed food is making our bodies unhealthy, processed EEG is making dummies out of our brain. There is so much information that can be obtained from a raw EEG or a less processed EEG than the indices that we use, which are highly processed, such as BIS. So this is a picture of a raw EEG. For anesthetic purposes, this whole scalp is not covered. We use 2, 4, 6 or 8 electrode montage and on both sides of the brain. This is a raw EEG, and each EEG wave is made up of different waves of differing frequencies. So can I have the next slide, please? The normal adult brain waves are divided into, basically they're named from delta to gamma and increasing in frequency. So the delta is when we are in deep sleep with the lowest frequency, and beta is actually the frequency that we managed to reach. Gamma is for seizures, etc. Beta is when we are focused. Right now, I think most of us would be at delta or theta range. Theta is normal sleep, or delta range would be the deep sleep, which is about 0.1 to 5 Hertz. Can I have the next slide? So this is what a normal EEG of a brain that looks like. Now, there are some properties of an EEG that we need to know. First is continuity, that there will be no periods of flat or isoelectric line in a normal EEG. Second is symmetry, that both the right and the left side of the brains will be largely same in terms of amplitude and frequency. The third is anterior-posterior gradient, that as we move from the front of the brain to the back of the brain, the frequencies will decrease, then the amplitude will increase. So the amplitude increase and frequency decrease will give rise to the posterior dominant rhythm that we have over the occipital region, which is normal EEG. When we are quiet with eyes closed, the alpha rhythm that we get. Now, some processing of EEG is required. We cannot monitor real-time EEG and do all the other monitoring and give feedback to the neurosurgeon. Even the neurophysiologists cannot do a real-time EEG monitoring from a raw EEG. So some processing is required, and the processing that we do is a spectrogram. Now, spectrogram is creating the EEG plot. It's basically a 3D plot. That is time over which the EEG is monitors is on the x-axis. The frequency is on the y-axis, and the power in each frequency is denoted as a color change. Can I have the next slide, please? So now, bear with me here. This is a little bit technical here. So the time, as we can see, is on the x-axis in the awake patient. This is the EEG spectrogram of a healthy volunteer. So the time is on the x-axis when the patient is awake. The frequency that we can see is 5, 10, and 15 Hertz, and it's on the y-axis. And the color changes that we see, basically it is not written here. To the right side, this denotes the power. So red is the maximum power, and the blue and green and yellow are basically very less power or no power. So all the frequencies that are dominating in the awake resting state are between the 8 to 10 Hertz that we can see in this red zone. So that is the spectrogram in an awake patient. Okay, so now we know that each anesthetic agent has a molecular target and the neural circuits that it acts upon. So it creates a brain pattern of EEG, which is easily reproducible, sort of like a signature of the anesthetic agents. So I'll show you a couple of signatures, EEG spectrogram signatures of propofol and ketamine. Similarly, all the anesthetic agents have their own EEG spectrogram signatures, which are easily reproducible, and we can see where the patient is on the spectrum of consciousness to unconsciousness. Now, these two spectrograms are showing, the first is where we see a continuous infusion of propofol. So this, it's actually wrongly written as 200 milligrams of propofol bolus. It is a continuous infusion of propofol. In the second one, we have given a propofol bolus. So we see differing EEG spectrogram patterns. The first, in continuous infusion of propofol, we see that the dominant frequencies, that is the red zone, is between the 4 to 7 hertz, which is the alpha oscillations. So this is an unconscious state. This is how it produces. This is in a healthy volunteer. The second thing that we've seen with a propofol bolus is that from about 7 minutes to about 15 minutes, we see this blue zone. Blue zone on the right hand side indicates a power of minus 20 decibels, which is, there is no power here, which means that it is isoelectric. Now, this is a region of burst suppression. And then from 15 minutes onwards, we see a similar pattern as in the previous one. The dominant frequency is in the 4 to 7 hertz. Now, this burst suppression is basically going to cause post-emergence delirium. So if we are monitoring an EEG spectrogram and we see this kind of a pattern, we know that we have given too much and we might end up in a post-operative emergence delirium. We need to reduce the infusion doses. The next slide, please. Now, this is the signature, EEG signature of ketamine. What we here see is high frequency. The EEG signature is high frequency beta oscillations. The maximum power here is in the range of, is in the yellow, and the red is in the range of about 10 to 50. I can't see your. It's basically in the 30 to 30, about 25 to 30 hertz, a little more than 30 hertz, which is the beta oscillations. So this is the maximum power. This is the signature of ketamine. Similarly, all the other anesthetic agents have their EEG signature. Now, what BIS does is it will process these EEG and give us a value, which is an index. It does not have any unit. And now that the fallacy of BIS is that it assumes that the same index value will have same level of unconsciousness for all anesthetics, which we know is not true. Because BIS value, if we've given a bolus of ketamine, the BIS value will increase because ketamine enhances. And also with nitrous oxide, the BIS value will increase. With dexmedetomidine, the BIS value will decrease to so much that it will show profound unconsciousness, whereas clinically, the patient will only be sedated. So this is how a EEG spectrogram is superior to BIS value in monitoring the unconscious level of the patient. Next slide, please. So the clinical use of a raw EEG is for intraoperative seizure detection. There will be a sudden increase in the frequency, sudden decrease in the amplitude. Since frequency and amplitude are inversely related, if frequency increases, the amplitude will decrease. Now, it will also tell us about acute cerebral ischemia. If it's happening intraoperatively, there will be EEG slowing. There will be increased theta and delta waves, or there will be more than a 50% decrease in the amplitude. Next slide, please. Next, what we have in a spontaneous electrical activity monitoring is the electromyography. Now, this is monitoring the electrical activity of the muscles using surface electrodes. Now, this EMG we use in our hospital in CP angle tumors. What we do is we place electrodes on the masseter and the orbicularis oculi to monitor the trigeminal nerve and the facial nerve. So in case the surgeon is near the facial nerve or irritating the facial nerve or the trigeminal nerve, we will get a muscle contraction, a buccal masseter contraction or orbicularis oculi, which will be recorded on paper, and the surgeon will be able to change his technique. So in this, what is essential is a bite block to prevent injury to the tongue or kinking or disruption of the ET tube. Now, the second part of the electrical activity is the evoked electrical activity. Now, there are several types of evoked potentials: somatosensory, motor evoked, brainstem auditory evoked, and visual evoked potentials. So what this is basically doing is that we are stimulating this is checking the neural circuits and the integrity of the neural pathway anywhere along the neural pathway. So for somatosensory evoked potential, we apply electrical stimulus to the median or the ulnar nerve for upper limb or tibial nerve for the lower limb. And we will detect this potential change on the contralateral side of the scalp with electrodes. The motor electric evoked potential is that we do a transcranial stimulation or a surface stimulation of the motor cortex. And then we can detect the signals at various parts along the spine or even at the muscle. Similarly, brainstem and visual auditory evoked potentials are used. Now, next slide, please. Now, as if this evoked potential monitoring wasn't complicated enough, we have to make our life difficult because there are so many confounding factors in anesthesia which make it even more difficult. So let's quickly have a look at those factors. First is hypothermia or hypothermia. Basically, we have to maintain the core temperature within 2 degrees of baseline during intracranial surgery because this will affect the hypothermia, will decrease the amplitude and will increase the latency of the evoked potentials. So will hyperthermia. Next is what will affect is hypo and hypercapnia. If there is hypocapnia, it will cause cerebral vasoconstriction, decreased blood supply, decreased cerebral blood flow, and this may lead to difficulty with the signal acquisition. So if you're trying to apply the stimulus and you're not getting any response, before jumping to conclusions about nerve injury along the pathway, we have to rule out hypocapnia and hypercapnia. The second is the next problem that we have is hypoxia and hemodilution. So we have to maintain a hematocrit of more than 30% with the normal PO2 levels because progressive hypoxia is associated with decreased amplitude of somatosensory evoked potentials and eventual loss of the RSACP waves. Then we have to think about hypotension. So if the mean arterial pressure falls below the autoregulatory threshold, we will get decreased amplitude of the evoked potentials. So if there is a signal change detected, if we are doing this, what we need to do is we need to increase the MAP to above 20% more than the baseline. The next confounding factor in this is our volatile anesthetic agents. And there is a dose-dependent suppression of the evoked potentials. The most sensitive being the visual evoked potentials and the most resistant being the brainstem auditory evoked potentials. Next, please. All our drugs will cause some changes. So intravenous anesthetic agents, they have similar changes as in volatile, but to a much lesser extent. And for this reason, propofol and remifentanil-tiva is the anesthetic regimen of choice when we are doing this intraoperative neuromonitoring. Now, when we are using propofol and remifentanil infusion, we might get hypotension and we have to mitigate it by using phenylephrine or metraminol or mefentamine infusions. Ketamine, on the other hand, has enhanced RSACP and MEP signals. So it can be used as an adjunct. In case the signal quality is not that good, we can tweak it with ketamine, but it can also precipitate seizures. Next, please. For obvious reasons, neuromuscular blocking agents do block motor evoked potentials and electromyography signals, so we have to avoid them. Next, please. Amongst the opioids, benzodiazepines, and alpha-adrenergic agonists such as dexmedetomidine, at low doses, they do not have much of an effect on these evoked potentials and can be used. So we can use a combination of these so that they have a synergistic action and the dose that we use of each of the components is decreased. Next, please. Now coming on to the second set of neuromonitoring, which is based on cerebral perfusion, of which the first is near-infrared spectroscopy. So what this basically does is it measures the regional saturation of oxygen. Next slide, please.
Sorry to interrupt. We are running a little short of time, so please.
Okay, so I'll just skip the principle behind it. Basically, the other is the transcranial Doppler ultrasound. which assumes that the vessel is the same, the vessel diameter is the same. So any change in the cerebral blood flow is because of cerebral ischemia. Next slide, please. Next slide. Intracranial pressure monitoring has been discussed. Now, next, please. Now, some lesser used modalities are, of course, the next, please. The brain tension, oxygen tension monitoring, and the biomarkers, brain injury biomarkers. These have not been validated in any trials yet and have not been recommended. They're only in the experimental stages. So we have quickly two clinical scenarios here. There's a 24-year-old man without any significant past medical history who presents for thoracic lumbar spinal deformity surgical correction, and the planned neuromonitoring modalities are the MEPs, SSCPs, and EMGs. So what we need to do is tailor our anesthetic plan. So what we need to consider is that the effect amplitude of evoked potential will be affected more than the latencies. MEP monitoring and electromyography monitoring will influence the anesthetic regimen because they are the most sensitive to the anesthetic drugs. So there are two, next slide please. What we can do is we can use volatile anesthetics with less than 0.5 max with an IV opioid infusion and avoid neuromuscular blocking agents. Or we can use TIVA with EEG BIS monitoring and avoidance of neuromuscular blocking agents. Next slide, please. Another clinical scenario. Do we have the time to do this or should I just skip this?
Yeah, you can continue.
Okay, so this is a 67-year-old male patient posted for carotid endarterectomy with prior history of previous ischemic stroke without residual neurological deficit. He is hypertensive on regular medication. So what are the neuromonitoring modalities that we would like to consider in this patient? Next slide, please. First would be the EEG. So if there is, during cross clamping, if there is an asymmetric change in frequency and amplitude, if it differs from the other side, we know that there is a cerebral ischemia that is happening. We need to release the cross clamp or insert a shunt. Second, next slide, a base value. So a fall in a base value of more than 14% is indicative of ischemia. So there's a high rate of false positive because if we give bolus of anesthetic drugs, obviously the BIS is going to fall more than 14%. But it has a very good negative predictive value, which means that if any point during the surgery, the BIS has not fallen beyond more than 14%, that means that cerebral ischemia is unlikely to have happened intraoperatively. Next slide, please. The third is this, somatosensory evoked potentials. So if there is cerebral ischemia, the cross clamping will cause sudden decrease in amplitude and increase in latency within seconds. Next slide, please. Of course, transcranial Doppler will show decreased cerebral blood flow in the middle carotid artery after cross clamping, indicative of need of shunting. Next slide, please. So this shows the upper figure shows the transcranial Doppler before cross clamping in a carotid artery endarterectomy, and this lower waveforms show the EEG. So this is before cross clamping, and we see a nice systolic and a diastolic waveform. Next slide, please. This is immediately during the cross clamp. What we see is that the transcarotid Doppler shows flat line, that there is no velocity happening on the middle cerebral artery. Also, EEG also shows relatively isoelectric. The amplitude has increased, the frequency has decreased. So what we need to do is insert a shunt. Next slide, please. This is after inserting a shunt. The transcranial Doppler velocity waveform has reverted back to its normal, as has the ECG. Next, please. The fifth is the near-infrared spectroscopy. Next slide, please. So we can use all these modalities. So basically what we do is that there is no single modality which is 100% sensitive and specific. However, we use a combination of these modalities to improve the patient outcome by preventing or early diagnosis and management of neural insult. Next. And of course, the future of neuromonitoring, as is the future of everything, is AI. So maybe there's going to be integration of all neuromonitoring modalities in one monitor, and that will be able to make the decisions to us that which intervention is most likely to prevent neural insult. Thank you. And this, next slide. And we welcome you to the RSACP Con in April 2026.
Thank you, Dr. Radhika, for your presentation. And now I'd like to invite our chairpersons, Dr. Kishore Arora, Dr. Minu Chalamanam, Dr. Mayank Masan, for their valuable inputs. And now the topic is open for discussion.
Excellent talk by all the three speakers. They have really enlightened us on all the three important topics of neuroanesthesia. Now, one thing I'd just like to ask Dr. Gorita is that she mentioned that for intubation, you use succinylcholine. Would you recommend succinylcholine in today's scenario when we have better drugs for faster intubation?
Ma'am, actually, whatever literature, ma'am, am I audible?
Yeah, you're audible.
So the literature that I have gone through, and as I mentioned earlier, that I have used the guidelines given by the Brain Trauma Foundation and the American College of Surgeons. They have both mentioned that the use of succinylcholine in a dose of 1 milligram per kg is not associated with a significant rise in intracranial tension. So there is no evidence to like discontinue the use of succinylcholine. But having said that, since we are having rocuronium now freely available and it is there in most of the centers, we could use either of the two drugs. But there is no evidence that succinylcholine in a dose of 1 milligram per kg should not be used for patients with traumatic brain injury. These are what I read in the recent guidelines.
Okay. Secondly, I'd just like to add a comment for Dr. Dipti Saxena is that ERAS in neurosurgery is basically dependent on the patient's individual needs and a specific surgical procedure. It is not generalized for neurosurgery as such.
Exactly, ma'am. That is why I told that the backbone of ERAS protocol in cranial surgery is patient selection.
Yeah.
Basically, in the case of ERAS protocol in neurosurgery, specifically regarding the epilepsy surgery, where we have to identify the seizure point and we are doing an awake craniotomy. So that is one of the indicators that they are thinking about to include into the ERAS protocol now.
Yes, sir.
As of now, for neurosurgery, there is only and only recommendation for thoracic and lumbar spine surgeries for ERAS protocol. Not even for the cervical.
Not even for thoracic as well.
Not even for cervical. Thoracic, they are just recommending only one surgery to be done under ERAS, which is dorsal laminectomy.
Yes, sir.
Apart from that, they are not even recommending the fixation to be included into the ERAS protocol.
Yes, sir.
And regarding the choice of the fluid in the case of the traumatic brain injury, now the current guidelines as of TBI Foundation, it is normal saline over balanced salt solution till there is a definitive decompressive craniotomy that has been done.
I congratulate all the three speakers for such a wonderful and illustrative talk on neuroanesthesia. The doubt I had also for succinylcholine, but Gorita has cleared it for the literature of Traumatic Brain Foundation. No? Any other questions from audience?
I have one question for Dr. Gorita regarding the prevention of seizures in traumatic brain injury. Would you recommend to repeat the dosing after the decompressive craniotomy has been performed? Any guidelines on that?
Yes, Dr. Mayank. They are suggesting that after the decompressive craniectomy, the guidelines which are mentioned in the BTF 4th edition are suggesting that it should be continued for at least 48 to 72 hours after the decompressive craniectomy has been done, and maximum number of days that it can be given is up to 7 days post the initial trauma. After that, there is no role of using anti-seizure prophylaxis.
And are they recommending levetiracetam or they are
No,
recommending
they are saying that no
eptoin
drug is
sodium?
superior. You can use any drug. That is dependent on the surgical neurosurgeon preference. In our institute, we are using levetiracetam.
Thank you so much. Thank you.
Thank you, sir.
Any other questions from the audience?
I think there are no further questions, and it was a wonderful presentation from all the three speakers and all the very important topics: traumatic brain injury, eras, and monitoring. Dr. Vikas, over to you, please.
Yeah. Thank you all the speakers for such an interactive session. And now I'd like to invite Dr. Meenu Chadha, madam, to give vote of thanks on behalf of Indore City branch.
Yeah, I would like to first of all thank all the esteemed speakers for sharing their expertise and the valuable insights for all the important topics. Then I would like to thank all the attendees who have attended this webinar for giving a good audience and having a good question answer session. And lastly, I would like to thank the RSACP National who continue to hold these webinars and do a wonderful job. Thank you very much. And lastly, I would like to invite all of you to Indore for the conference next year.
Thank you very much. And on the behalf of RSACP National, me too would like to extend the invitation to all the audience to please register and come to RSACP Con 2026 in Indore, which would be a great academic event. Thank you very much and good night.
Good night, sir.
Good night. Thank you very much. Long live RSACP.
Thank you.
Long live RSACP.